Welcome to the Go-To Physio Show. Coming up on today's show, we take you through a real-life ankle joint assessment, how to make sense of the symptoms that your patient presents with in the real world, as well as some nice, easy, objective assessments that I use on a daily basis. In addition to that, to help you grow your business, I'm going to take you through one technique that is very underutilized but can have massive consequences to your profit in your private practice. And we'll also cover in the Brain Booster a technique that you can use when a patient is having a bad day. I hope you enjoy the show. So welcome again to another episode of the Go-To Physio Show. So we've got two more episodes after today's for season one. And season one, we're focusing predominantly on the lower limb. And we're going to continue our journey today now with the ankle joint. Now, again, everything we're going to cover today, that's going to be finding the 20% that we're going to focus our attention on, okay? So our attention will be focused, 20% of it will be focused on the tissues that we are thinking are contributing significantly to the pain experience. The 80% of our attention is what's caused these tissues to be stressed in the first place, if it's obviously a non-traumatic injury, okay, or pain. So what we're going to do with the ankle, the key performance indicators with the ankle that we're going to use would be mainly our knee to wall for dorsiflexion and also plantar flexion tests such as a calf raise. They will be two that we're going to go through in a minute, but what we want to do before that is we just want to start to make sense of what we're going to see when we put this patient in standing and we actually have a look at these two tests, okay? So what I usually will do with the ankle, again, we will have looked at the whole body with our generic objective, we would have looked at other parts as well to see what's contributing to it, but for our local ankle assessment, some things that I like to do, the first thing out of habit, okay, is I want to clear a syndesmosis, okay? So again, syndesmosis, hands down, is probably the most missed diagnosis that comes into the clinic here in private practice for myself. I've been exposed to, well over 50 of these now, I reckon, over the last 10 years, okay? And again, that doesn't sound like a big number, but it's actually, it's an injury that you may not have been exposed to unless you were, I suppose you could say lucky or unlucky in some regards, but in rugby league, especially in rugby union, working in that over the last 10 years, I've seen my fair share of these, okay? So the big one that I'm going to check with a syndesmosis, and I do this routinely, is the dorsiflexion external rotation test. So I'll cup the ankle at the calcaneus, okay, or sorry, the foot at the calcaneus. I'll keep the knee at 90 degrees, and all I want to do then is I want to externally rotate the full foot. So what happens here then is when I cause that rotation, that's going to cause a rotation in the talus, which is then theoretically going to gap that tib-fib joint, which is going to stress that syndesmosis joint or the inferior tib-fib ligaments. Okay, so obviously we've got anterior, we've got posterior inferior tib-fib ligaments. If the anterior ligaments are torn, then the person may be still quite good functionally, okay? If the posterior ligaments are torn as well, then from my experience, I usually would send them for a surgical opinion, okay? Now, the tripwire with these syndesmosis injuries is, if you do have a positive, is that there's not a lot of swelling usually. There's not a lot of swelling presents. The person feels okay. It's just a little bit sore. They feel like they don't have much power in it. But the ankle joint itself, it looks quite good usually. Okay, so that's where a lot of people are like, that's not too bad. But then if you don't do your key performance indicators, okay, you'll get cut out. Whereas if you use your key performance indicators, it'll be clear as day that it's a syndesmosis, and I'll show you that today, okay? So that's the first test I'll do, and this one is very, very sensitive from my experience, and I know the literature covers it as well, and we're going to cover that in a later episode today. The other test that I'll use for a syndesmosis is a squeeze test, okay? So what I want to do is I want to get the tib-fib. Now don't forget the fib's going to be slightly posterior in that transverse plane, okay? So I just want to get them here. I just want to squeeze. Imagine a chopstick. I'm going to squeeze, if I squeeze this end, it's going to gap that end. Okay, I didn't do that analogy very well. So what I'm trying to do here is I'm going to squeeze this end, which is going to gap that end. It's going to stress the ligaments and elicit a pain experience. Now this one, from my clinical experience, it doesn't always elicit a pain response, but usually the dorsiflexion external rotation will elicit it. And even if I miss those and I'm not very good at those tests or I didn't stress it enough, I'll still be able to find the syndesmosis usually with my calf raise. Okay, so don't stress too much about it. I'll always tell the story in Leeds when we had a player, took him off, and we got the doc to have a look at him, and the doc just went through the motions. Okay, yeah, syndesmosis is fine, and myself and the other physio at the time were looking at each other going, what the heck? So we had a look at it then. I had a look and I gave him a good squeeze, and he nearly jumped off the bed. Okay, so again, I'd rather you be a little bit more aggressive here with these and not miss it than rule it out because you haven't stressed these tissues enough. Okay, so if you find, you cause a little bit more trauma to the fibers, I'd rather that than miss it, alone walk on it for the next 2-3 weeks. He's got a raging synovitis in the joint, then that flares up, and then he's looking at 12 to even 16 weeks sometimes with those when they get really bad. Okay, so the squeeze test is very useful as well. If they're ruled out, they're pretty good, then we're okay at the moment. Okay, so what we'll do then obviously is I'll just do a plantar flexion inversion, have a look. Again, I like to feel that ATFL, and a lot of people, they'll have ruptured them long ago. Okay, another thing I like to do is I want to push into the ball of the big toe. So I'll get the ball of the big toe, I'll get the athlete to push down into there, push there for me, Pete. Again, I want to load that peroneal. So all I want to see here is, can he get into an isometric contraction? And he can there. And then I'll load the ball of the little toe, push again, Pete. Can he get that tib post to work isometrically as well at some point as my pressure meets his pressure and these tissues contract? Again, that's going to be important when we want to brace through that foot when we go up onto that calf raise. Okay, so that's something that I look for. And then another one, passively dorsiflexion inversion. That's another big one as well for any protective tone through the peroneus brevis in particular. Okay, so a lot of ankle sprains will see that peroneus brevis wants to lengthen, and after they've resolved, even old ones, this can be quite sensitized still. And again, that's going to be important dorsiflexion inversion for heel strike. Okay, when we're walking. So we want to be able to lengthen those tissues and tolerate loading in that direction. Obviously, we can still look for any tenderness along the cuboid. The navicular is a big one as well. Okay, we want to rule out a stress fracture there, and the malleolus as well. Okay, and obviously the distal tip of the fibula as well, in case there's any potential fracture there on the back of that as well. Okay, so that's just your generic stuff. The big thing here is the syndesmosis. Get used to that. Replay this teaching content and get used to testing that. Now we'll get Pete up then, and we'll do 2 KPIs that I like, which is the knee to wall test and the calf raise. So the first KPI that I like to use is the knee to wall. Okay, so again, the weight bearing lunge test or whatever they call it. Okay, so all we're going to do is we're going to get the knee to touch the wall without the heel coming up. And we're going to get that measurement from the wall to the toe. Now be careful, we've got a skirting board here in the clinic, so you'd want to take that into consideration as well, because then in the next time you test them, if you're on tour or whatever and you do it and they don't have a skirting board, you're probably going to be about 2 centimeters off. Okay, so again, you can measure the depth of the skirting board if you wish. Okay, but you're just looking, okay, to get to that point where they can just do it without the heel coming off. Okay, so Pete, if you just go through that, again, I'll get my ruler then and I'll measure the distance from the big toe, okay, to that wall. Okay, and then I usually like to compare to the other side, and roughly speaking, we're looking for 10 centimeters, okay, plus. But look, I've had some athletes and they haven't been able to get anywhere near 10, and they've been quite durable. So just take that with a pinch of salt. The big thing here that I want to know is, where do they feel the restriction? Do they feel the restriction in the front of the joint, or do they feel it in the back in the calf soleus? Okay, so if they feel it in the front, then I'm thinking that there may be some protective tone around maybe some of the ligaments in the posterior side of the ankle. If they feel a protective tone in the calf, then I'm thinking it could be potentially the soleus or one of the other tissues in the deep calf. Okay, that has some kind of protective tone that's not allowing these tissues to lengthen. in my mentorship, I'd go into this in a lot more detail, and we'd start to clinically reason and figure out exactly what structures are more likely to be contributing to this restriction. Okay, but if they've got full range of motion there, happy days. So that would be one of the KPIs that I'm working on in my first session. Let's get back as much range of motion as we can through that ankle. That's going to be important as we get to actually tolerate loading through the ankle. Okay, especially for deceleration as well, we're going to need a little bit more of a bent knee. Okay, the other big test then, if we just use the corner of the room here, Pete, is the calf raise. So I'll usually get them to do it bilateral first. Okay, so just go up on your toes, Pete, and then I'll get them to do it single leg. Okay, and then just lift one leg, Pete, and then do the other one. Okay, good. And then you can see Pete here. Okay, what I want to see is, does he go all the way up and lock out? Okay, so Pete's a bit lazy here, like most athletes. Okay, if we call you an athlete, Pete. I'm only joking. So calf raise again. Okay, good. Now, has Pete anything else? So go a little bit higher for me, Pete. Pete, go, 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 go. Good. Can he get all the way up and lock out there? Okay, so a lot of athletes, they'll just go through the motions. That ability to lock out, we're going to have a lot of bracing happening through tib post, but more importantly, peroneals. Okay, so just because an athlete can't calf raise, it doesn't mean they have a weak calf. Okay, now what you're going to find with an athlete that has a syndesmosis injury is they will not be able, or a significant syndesmosis injury, is they will not be able to do that calf raise. Okay, they'll want to do it, but the brain just will not let them do it. Okay, and again, their brain presumably knows that if they do a calf raise, that's going to gap the joint. They don't have the stability there to allow these muscles to generate torque and power to actually get them up. So what you'll look like here, you just step away for a sec, Pete, is you'll see something like this, where they're trying to use their shoulder, and they're just trying to do that, and they're just like, I can't do it. Okay, so that to me then is a classic. Okay, syndesmosis is probably going into my the top of my list, and again, we'll get their injury history, their mechanism will give us a big clue as well. And the other one, if you go up again, Pete, what I'm looking for is, does Pete have good intent through the ball of the big toe when he comes up? So if you bias your little toe here, Pete, go up through your little toe, you'll see that they'll tend to put their weight more laterally. Sometimes the calcaneus will supinate quite a bit. Okay, and then if you push it all through the big toe, Pete, okay, and then you'll see here it actually E versus E, plantar flexes. Okay, so if we see one or the other excessively happening and it's a big elephant in the room, then that to me then will be suspecting, okay, maybe he's not happy to load his tib post and not those tissues, or maybe he's not quite happy to load his peroneals when he pushes through his big toe. Okay, so again, that's just giving me good information. What I want to have, ideally, with these two KPIs, we're going to cover this in the ankle joint return to play the next episode, is my first session, that's all I worry about, is just getting the two of those back to some form of baseline, and then we start to worry about getting the athlete back to the next level of loading after we do that. So we want full range, we want to restore the calf raise. All my attention, all my intervention from that 20% is going to be focused on those two KPIs. 80% of my attention is going to be focused on what caused these tissues to load excessively in the first place if there wasn't a genuine mechanism. So when she reaches, what I'm looking for is, does her...
I'm bringing the knee down towards the bed. Good. Just change the angle so you can see it on the camera. So I'm just going to get into that great as you can there. Sink into the tissue. So again, I'm just sinking in a little bit. Again, it's just under the skin, so I don't need to go that deep.
Once you understand the principles of what we're trying to do, take slack out, put slack in, and this is what's going to differentiate you a lot from other therapists, is we're not just going to...
You get results and you get them quickly, but apart from that, they stay.
Okay, so the first test I use with dorsiflexion is I'll get a meter ruler. Okay, something like this works really nicely in the clinic because you can do some nice tests with it, and you know, obviously it's not too big and you can move it around. So we obviously want the 0 centimeter to start at the wall. Now I've got a skirting board here. Okay, so that skirting board is exactly 1 centimeter. So we need to know that, because if the person's doing this at home, or you're doing it maybe even if you're working with a team and you're doing it somewhere else and there's no skirting board, your ankle range will be out 1 centimeter. Okay, now you can use this, and I've also just put zinc oxide tape on the floor and measured 1 centimeter increments on the tape as well. So you don't necessarily need this. You can just get a ruler, measure it with tape, and then put it on your actual clinic, and that's what we used to do with the Giants for 3 years. Okay, so you're just going to pop it here, and all Pete's going to do is he's going to put his knee to the wall without his heel lifting. Okay, so just do your knee to wall test. Okay, most people will be aware of this test, and all we want Pete to do is we want him to come back as far as you can without the heel lifting. Okay, pretty straightforward. Okay, good. And then what I want to know here, okay, besides the obvious differences left and right, is I want to know where Pete feels the restriction, okay? Where is his conscious experience of the restriction, okay? So what the usual options will be either in the front of the ankle or the back of the calf, okay? So you'll just feel a generic tightness, or you'll feel, usually they'll report a pinch in the front of the ankle. That's usually the two that we're going to see. Okay, so Pete's just working away here. He's getting that sweet spot where he can just get his knee to the wall without the heel lifting, okay? And again, if you want to standardize, you can keep the knee over the second toe here, okay, for standardization purposes when you retest your athlete. But for me, you know, I don't pay a great deal of attention to that, if I'm being honest. I just see how they get there, okay? Now, obviously, if Pete's doing it and his knee kind of dives inwards, okay, then, you know, I'd want to take that into consideration. Why is he doing that? What's not lengthening? That's maybe causing him to drive his knee in there. But for most people, they'll put it over the first or the second toe. Okay, do you have your range there? So Pete's got 6 centimeters. Usually we like people to have about 10 centimeters. Okay, there is a little bit of research suggesting that 10 centimeters may be optimal. Okay, so just switch sides, Pete. Okay, then I want to compare left and right. And sorry, the one thing I didn't ask Pete there is, Pete, where did you feel the restriction when you were doing that? Down the back of the calf. Okay, so that tells me that those tissues maybe are not lengthening, or that you might be carrying some kind of protective tone there. Okay, now if Pete had 10-12 centimeters and he felt just a nice stretch there, that's okay. But usually what people will feel, or what they'll say when they feel that, is it almost feels just like a block. Okay, that's a phrase, or just feels locked. Okay, so let's just get Pete's other side. Okay, so he's got 9 centimeters on the left. Where do you feel a restriction, Pete?
In the front there.
In the front. Okay, whereabouts? Okay, in the front. Cool. So he's said it's in the front of the ankle joint. Okay, so in the talus. So usually when somebody gets a pinch in the front of the ankle, that's usually, how I interpret that, is a joint problem, okay, where the talus potentially isn't going back into the mortise and they're almost getting a nip or a pinch in the front of the ankle. Okay, so if that talus can't go back in, you tend to usually get a pinch. If the person's reporting on the back, the tightness, okay, so Pete's actually got left and right here. He's got one in the front and then his other one is in the back. That's usually what I would consider protective tone. Okay, so Pete, I would suggest his protective tone in the posterior calf muscles on the right, and he's got protective tone in very, very close around that ankle joint. Okay, so something's not lengthening in the left ankle joint to allow that talus to go into that mortise as that tib and fib come across, okay, or come over it. The Therapist Mentorship Program was put together to help you accelerate your ability to have confidence and clarity with any patient that comes through the door. It's a very intimate 90-day experience where you work closely with myself and my most trusted therapists to put together a very, very specific structure in your assessment, your treatment and your rehab for every single patient, so that you can truly get the results that both you and your patient deserve, so you can become that go-to therapist. If you want more information, just click on the button below this video or go to thegotophysio.com/mentorship. Hey, welcome to the Go-To Therapist Build Your Business segment, the segment that's going to help you build your business to truly become that go-to therapist. Now, this week's tip, it's all about keeping in contact with past patients. So a lot of patients, they've got new problems, or they've got maybe some of the old issues have returned, and they've been meaning to ring you. They've been meaning to get in touch, but life gets in the way. Just like we talked about last week, life gets in the way, they get distracted. So one thing, or one strategy that we can do, is we can email our patients on a weekly basis. Now, what happens when you email a patient on a weekly basis is you'll do it for 2 weeks, and then you won't get round to it again for another 4 weeks, because your life will get in your way, okay? And then you'll do it again sporadically. But if you're disciplined and consistent emailing every week, your patients get used to it. They almost look forward to the email. Now, next week I'm going to tell you what to put in and what not to put in the email. But what will happen by sending that email is you'll stay at the forefront of their brains, okay? So the amount of emails that we get back saying, oh, I've been meaning to contact you, have you got any slots free this week, okay? You'll get a lot of that back if you do this right and you do what I'm about to tell you in next week's Build Your Business segment, okay? But it keeps you top of mind, and also for patients who are doing really well, you're still in their mind. So then when someone else says to them, oh, my back's killing me, or go, wow, what's wrong with you? Oh, my knee is sore. Oh, you need to go and see Dave, you need to go and see Pro Sport Physio, okay? So there's a few things that happen when you consistently email your past patients. Now, obviously, these days, because of GDPR, etc., you need to have permission to email any new emails that you've acquired, okay? But if you have all your old patient emails, you've absolutely no problem. You just obviously need to make sure that you give them an option to unsubscribe as well, okay? And for any new patients, you just need to make sure that you have permission to contact them on an ongoing basis, okay? So again, have a think about that, start getting your strategies ready, and then next week's show I'll show you what not to put in, and then also what you need to be saying to get the maximum return for your efforts in emailing your past patients every single week.
Physio, and I work in private practice in Tullamore. So before the mentorship, I suppose my biggest challenges was I was getting frustrated that I wasn't seeing results. So patients were kind of leaving, they were getting frustrated that they weren't seeing results and they were kind of dropping off. And same for me as a therapist. So I liked the way Dave had a structured programme. He followed a complete step-by-step approach, and that really attracted me. And it kind of sounded like something that I would really benefit from. So the mentorship really helped me with my confidence. So I was really confident in the approach to the patient, my step-by-step guide, and then I was really confident in my muscle testing and the exercises I was giving patients. So confidence, I think, was the biggest thing for me. So during the mentorship, I suppose the biggest thing was just piecing everything together. I just couldn't believe how simple it was to follow, but it was very effective. So I suppose it was just maybe following everything, just to the guide that Dave gave us. It's so much easier now because I have my little my pathway, so I can follow my pathway, see where I'm going wrong, just follow those pillars, and it's really easy to spot signs of where you're going wrong or where the patient needs more help, and you can really address your focus in on those. So it's really good for pinning down stuff like that. I'd say if you're thinking about it, definitely go for it. You'll get so much confidence, it's very rewarding. There's so much support out there from Dave on the Facebook group, and you might feel like you're alone, but you're not. Like it's any problems you have with patients, you can just stick it up in the Facebook group. So mostly the support and the backup you get from Dave is excellent.
Hi guys, welcome to another episode of The Brain Booster with Carl Morris. Delighted to have you back on again, Carl. And Carl, let's get back where we left off in the last episode where we talked about the importance of building confidence for that patient. Now, with persistent pain patients who are non-sporting usually, although some can be, their confidence has really taken a real big insult, so to speak, where they lack confidence in movement, in the ability to do daily activities, things that add value to their lives. So could you just talk a little bit more about confidence and how we as therapists or coaches, as I like the way you're going with that, have an ability to help that person build their confidence back up again?
I think confidence is an interesting one, Dave, and a lot of the things that attach or create confidence are the images that we run through our head and the language that we use to ourselves, the story that we create about our own narrative. And, you don't have to be a sportsman or woman to actually use this, but you can use something that's been proven very effective in the sporting environment. And that's the power of imagery, the power of visualization, to actually, actively engage your brain you know, and it's something that we've done with athletes together, is to get them, you know, there's different kinds of imagery that they could use. But one of the things that I really like the idea of is that, you know, when you're at home, it's just whatever site of injury you have on your body, just engage imagery to see that growing stronger, to see that getting better, see the movement that you will be making in the future. And I think one of the most important things that you can do, for instance, with a rugby player, what we would have done in the past is somebody with a long-term injury. It's very, very important that they do some mental imagery of being back on the pitch, of being back playing, and actually imagining that playing better than ever. So you're planting these seeds, and these seeds can start to build a sense that, yeah, the future, we can build towards that. So that starts to build some confidence. It does tie in also with the good days principle that we've mentioned previously as well, putting in good days. But I think, you know, they say you don't have to be an athlete to do this. You can visualize yourself, you know, walking with the kids again, being out in the park, playing football, whatever it may be. But it's actually about that individual responsibility to create these images. Because if we leave it to the brain will very often just create lots of negative stuff. You know, we tend to, you know, forecast disaster, things like that. So actively visualize yourself being back, being better, being stronger. I'm not saying that's going to make things happen, but it certainly assists it incredibly well. And, you know, being confident about it is a big part of recovery.
It's absolutely brilliant, Carl. Again, real, not, don't mean disrespectful, but easy ways that we as therapists could implement this in the real world. And that's absolutely brilliant. And again, thanks very much for joining us, Carl. We're going to talk a little bit more about this in the next episode, but I think there's a lot there for therapists to go back, watch this over 5-6 times, what you just said there, and apply this in the real.
You know, and I think for the therapist as well, that a lot of clients will have been to therapists previously and not been given any of these things. So when the therapist becomes the coach as well, you know, you're providing a very, very valuable service to people, a very, very valuable service that assists recovery. You know, but it's things that people talk about. You know, you're distinguishing yourself as a therapist by what you're offering. You're not only offering a great knowledge of the body, but an actual understanding a little bit more of how the mind works as well. And we'd be fools to actually discount the two. You know, it's a symbiotic system. We've got to work with the whole thing rather than just the injury site.